adenocarcinoma of prostate. In United States, adenocarcinoma of prostate is the most common form of cancer in men. And prostate cancer is the second cause of cancer-related death in men, surpassed only by lung cancer. Now, pathogenesis. Pathogenesis of prostate cancer is mainly environmental exposure and inherited genetic factors contributes to striking difference in the incidence of prostate cancer across geographic locales. For example, the incidence of prostate cancer in individuals of Japanese descent living in the United States is substantially higher than in Japanese living in Japan. As explained below, some genetic factors appear to increase risk due to increased effects on prostatic epithelium. The main reason is prostate is an androgen sensitive organ. So, androgen hormone plays an important role in pathogenesis of CA prostate. Androgens and androgen receptor function have central role in the development, progression, and treatment of prostate cancer. Environmental factors. Exposure to carcinogens, estrogens, and oxidants damage prostatic epithelium. Western diet, charred red meat, and animal fat. Why? Because it produces heterocyclic aromatic amides and polycyclic aromatic hydrocarbons. These are the play key role: heterocyclic aromatic amides and polycyclic aromatic hydrocarbons. And also play a key role polymorphism in glutathione S transferase, GSPP1. This is an enzyme involved in detoxification of polycyclic aromatic hydrocarbon. And inherited genetic factors like M1C and BRCA2 and DNA mismatch repair genes. Now, the androgens. Like their normal counterpart, the growth and survival of prostate cancer cell depends on androgen, which bind to the androgen receptor and induce the expression of pro-growth and pro-survival genes. Androgen hormone plays the key role in pathogenesis of CA prostate. The importance of androgens in maintaining the growth and survival of prostate cancer cell can be seen in the treatment with anti-androgen, which usually induce disease regression. Unfortunately, most of the tumor become androgen blocked, androgen resistant. Acquired genetic and epigenetic alterations. The most common genetic alteration in the prostate is a chromosomal rearrangement that juxtaposes the coding sequence of ETS family transcription factor gene, most commonly ERG or ETB1, next to the androgen regulated TNPRSS2 promoter gene. Amplification of MYC and deletion of P10, both of which accelerate cell growth and may contribute to resistance to anti-androgen therapy. In late-stage disease, loss of TP53 and deletion of RB gene are common, as are amplification of AR gene. So, these all are involved in pathogenesis of CA prostate. Amplification of MYC, deletion of P10, loss of TP53, and deletion of origin. Now, precursor lesion. Precursor lesion of CA prostate is Prostatic Intraepithelial Neoplasia or PIN. It is the precursor lesion. From PIN, CA prostate develops in most of the cases. Both PIN and cancer typically predominate in the peripheral zone and are relatively uncommon in other zones. Now, hormonal dependency of CA prostate. Androgens are considered essential for development and maintenance of prostatic epithelium. But how androgens are responsible for causing malignant transformation is not yet clear. But there is some evidence we know that androgens play a key role for development of CA prostate. Like orchiectomy causes arrest of metastatic prostate cancer disease because testes being the main source of testosterone. And second number is administration of estrogen causes regression of prostatic carcinoma. Cancer of the prostate is extremely rare in humans and in patients with Klinefelter syndrome. Cancer of prostate begins at the stage of life when androgen levels are high. So from these are the evidence. Now this is the pathogenetic mechanism of CA prostate. It starts from MYC variants, then TMPR SS gene, and it is called PIN. So you can see in stage of PIN, breastplate membrane intact. There is no invasion in PIN. And this is the adenocarcinoma of prostate. Here, invasion occurs. And here, loss of P10. And telomerase activation. When loss of P10 occurs, then invasion happens. And then metastatic prostatic adenocarcinoma, and at last, androgen receptor mutation, MYC amplification. Now, clinical features. Urinary obstruction with dysuria, frequency, retention of urine, hematuria, and 10% of cases pain in the back due to skeletal metastasis. By the time symptom appears, carcinoma of prostate is usually palpable on digital rectal examination as a hard and nodular gland fits to the surrounding tissue. So, if we do digital rectal examination, the fillings will be hard and nodular gland. Okay. Two biochemical serum tumor markers employed. One is prostatic acid phosphatase or PAP is secreted by the prostatic epithelium. Elevation of serum level of PAP is found in cases of prostatic cancer which have extended beyond the capsule or have metastasized. And another is prostate-specific antigen or PSA. This is important. PSA. PSA can be detected by immunohistochemical method in the malignant prostatic epithelium as well as estimating serum. The normal level is 0 to 4 nanogram per ml. Normal level of PSA is 0 to 4 nanogram per ml. Between 4 to 10 nanogram per ml is suspicious of CA prostate, and more than 10 is diagnostic of prostate carcinoma. Now, second line screening test. Second line screening test, the name is 4 prostate specific calicularis. First is measurement of total PSA, then measurement of free PSA, then measurement of intact PSA, and measurement of human calculin 2. These 4 markers consist of 4 prostate-specific calculins: total PSA, free PSA, intact PSA, and human calculin 2. এটা হচ্ছে কি হ্যাঁ আমার মনে হচ্ছে 15 মেকানিক্যাল লাগিয়ে দিচ্ছে। The diagnosis of prostatic carcinoma can be made by clinical, biochemical, radiologic, ultrasonographic, cytologic or FMSC and histopathologic method. Histopathologic method consists of core biopsy, TUR specimen or radical prostatectomy. However, for definite diagnosis, triple approach is most commonly followed. DRE is digital rectal examination, serum PSA determination, and transrectal ultrasound guided core region biopsy, TRUS guided CNV. So, this triple approach is the most commonly followed. DRE, serum PSA, TRUS. Now, morphologic features. Grossly, the prostate may be enlarged, normal in size, or smaller. In 95% of cases, prostatic carcinoma located in the peripheral zone, especially in the posterior lobe. Malignant prostate is firm and fibrous. So, grossly, we cannot identify it is a adenocarcinoma of prostate. That's why microscopic is important. Microscopically, adenocarcinoma, transitional cell carcinoma, squamous cell carcinoma, and undifferentiated carcinoma. Apart from this, there is a long list of histologic types of cell prostate, but for your level, these 4 are important for you. Adenocarcinoma of the prostate is the most common type found in 96% of cases and is the one generally referred to as carcinoma of prostate. Now, histologic characteristic of adenocarcinoma of prostate. Architectural disturbance. Normally, normal structure, microscopic structure of prostate, there are 2 layers of prostate. And there is intra-acinar papillary convolutions are there in normal prostate. But in case of adenocarcinoma of prostate, there is loss of intra-acinar papillary convolutions. The group of acillae are either closely packed in back-to-back arrangement without intervening stroma or are haphazardly distributed. So in normal prostate, there will be presence of intra-acinar papillary convolutions. In case of adenocarcinoma of prostate, there will be loss of these intra-acinar papillary convolutions. Now stroma. Normally fibromuscular skin surrounds the acillae, whereas malignant acillae have little or no stroma between them. Gland pattern, most frequently the glands in all differentiated prostatic adenocarcinoma are small or medium sized, lined by a single layer of cuboidal or low columnar cells. Moderately differentiated tumors have febriform or fenestrated glandular appearance. Poorly differentiated tumors have little or no glandular arrangement but instead show solid or trabecular pattern. Then tumor cells, the outer basal layer seen in normal or benign acillae is lost. Normally, outer basal layer will be present, outer basal layer. But when it is adenocarcinoma of prostate, that outer layer will lost. Outer basal layer will lost. Only tumoral cell layer will present. The tumor cells may be clear, dark, and eosinophilic cells. Clear cells have polycytoplasm, dark cells have homogeneous basophilic cytoplasm, and eosinophilic cells have granular cytoplasm. The cells may show varying degree of anaplasia and nuclear atypia, but is generally slight. The most important is invasion. For any type of malignancy, invasion is the most important part. Without invasion, we cannot tell it is a carcinoma. One of the important diagnostic features of malignancy in prostate is the early and frequent occurrence of invasion of intraprostatic pedineural spaces. Histologically, the glands are typically smaller than benign glands and are lined by a single uniform layer of cuboidal or low columnar epithelium. In case of malignancy, there will be a single uniform layer of cuboidal cell. Basal layer of cell will be absent. In contrast to benign glands, malignant glands have tightly packed cells and characteristically lack branching and papillary infolding. Benign characteristically lack branching and papillary infolding will present, but in malignancy, lack of branching and papillary infolding. The outer basal cell layer typical of benign gland is absent. Nuclei are enlarged and often contain one or more large nucleoli. Now, prostatic intraepithelial neoplasia. This is the, I told, it is the precursor lesion of CA prostate. So, it is important to differentiate between PIN and CA prostate. In approximately 80% of cases, prostatic tissue removed for carcinoma also harbors PIN. PIN consists of architecturally benign, large branching prostatic acini lined by atypical cell with prominent nucleoli that may be psychologically identical to carcinoma. So, PIN consists of architecturally benign, large branching prostatic acini lined by atypical cells with prominent nucleoli. But here, no invasion. Invasion will absent. Unlike malignant glands, glands involved by PIN retain at least partially a layer of basal cell and have intact basement membrane. So PIN have basal cell layer and have an intact basement membrane. So PIN shares some features of benign and some features of malignant features. It is a features of prostatic adenocarcinoma. These all are malignant glands. These large glands are benign. These are benign, but these are malignant. Here, these all are malignant glands. But these are benign glands. This is normal prostatic glands embedded in fibromuscular stroma. These are convolutions. Okay, and here two cell layers are present. Basal cell and cuboidal cells. Two cell layers are present and inner convolutions are present. And there is no invasion. And stroma are also present. These are stroma. These are stroma. Here you can see more better involutions. These are all benign glands. And these are all stroma. This is stroma. This is stroma, this is gland. Benign gland. is all are stroma. 2 layers. These are basal cell layer, these are tubular cell layer. And these are secretions for coagulation. These are malignant glands. And these are benign glands. And it is stroma. You can see small glands. Actually, in prostate, it is opposite. Small glands means it is cancer. Large glands means it is benign. Small crowded glands and back-to-back arrangement. Back-to-back arrangement. These are all malignant glands. This is the same picture. These all small glands means malignant glands. Small glands with one single cell layer is and loss of convolutions means it is malignant glands. These are all malignant glands. These are malignant glands, these are benign. And you can see prominent nucleoli. Prominent nucleoli. These all are prominent nucleoli with single cell layer. These also some pictures. Nuclear enlargement with hyperchromasia, nucleoli, prominent nucleoli, intraluminal blue mucin. It is the perineural invasion. It is large. In the malignant glands, this is large. It is called perineural invasion. Now Gleason grade. Gleason grade, I think it is difficult for you, but just listen. There are grade group 1, 2, 3, 4, 5. Okay. It is called Gleason grade group. So, less than 6 is Gleason group, grade group 1, 3 plus 4 is 2, 4 plus 3 is 3, 4 plus 4 or 3 plus 5 or 5 plus 3 is 4. And 5 consists of 4 plus 5, 5 plus 4 and 5 plus 5. So, 1 is called only individual discrete well-formed glands. 2 predominantly well-formed glands. 3 is poorly formed fused glands. 4 is only poorly formed glands. And 5 is lack gland formation. It is the 1 closely packed oval uniform gland. Loosely arranged less uniform gland. Small pleomorphic gland, few small glands. Here it is no gland, sheet solid oligopapillary form. Now Gleason scoring. On biopsy, the most common and highest grade pattern on a given polar added. If 3 plus 4 plus 5 is present, Gleason will be 3 plus 5, a score of 8. So in a slide, if I found the most common pattern is 3 and least common pattern is 4 and least is 5, the score will be 3 plus 5, common and highest grade pattern. Common and highest. If there is 60% Gleason pattern 3, 35% Gleason pattern 4, 5% Gleason pattern 5, then it will be 3 plus 5. In all specimens, in the settings of high grade cancer, one should not report a lower grade if it is less than 5%. Less than if a grade occupying less than 5%, then in core biopsy, needle biopsy, we will not mention it. We will mention the highest pattern, common and highest pattern. If there is 98% lesion pattern 4 and 2% 3, then it will be 4 plus 4. I will not mention lesion score 3 because it is less than 5%. But on radical prostatectomy, the scenario is quite different. In radical prostatectomy, if there is a minor component, I have to mention that 98% pattern 3, 2% pattern 4, and minor high-grade component will like this 3 plus 4, 7, 2% pattern 4. So in radical prostatectomy, I have to mention the lower grade, that is less than 5%. You can see it is grade group 5 adenocarcinoma. It is sheet, composed of sheets of malignant cells with no identifiable gland formation. Grade no gland formation either. Now spread. The tumor spread within the gland by direct extension to distant sites by blood, lymphatic fluid. Direct spread, direct extension of the tumor occur into the prostatic capsule and beyond. In less spread, tumor may extend to bladder neck, seminal vesicle, tridon, and ureteral openings. Next, distant spread occur by both lymphatic and heterogeneous route. The rich lymphatic network surrounding the prostate is the main mode of spread to the sacral, iliac, and para-aortic lymph nodes. The earliest makes occur to obturator lymph nodes. Now, hematuria spread to pelvis, lumbar spine, other sites of metastasis are lungs, kidneys, breast, and brain. And one is retrograde spread by prostatic venous plexus or via systemic circulation. Bony metastases are typically osteoblastic. Most common bony metastasis is lumbar spine. Lumbar spine is the most common site of bony metastasis. Then proximal femur, pelvis, thoracic spine, and ribs. This is the picture of metastatic osteoblastic prostatic carcinoma within vertebral body. It is the most common site of prostatic carcinoma metastasis.